Right, good evening everyone and welcome to this Prostate Cancer UK webinar, End of Life, What to Expect and How to Prepare. I'm Sophie Steers, I'm a Senior Health Information Officer at Prostate Cancer UK and I will be hosting this evening. Before we get going properly, I just need to go through a little bit of housekeeping. Firstly, we are here on a Zoom webinar. This isn't the same as a Zoom meeting, so everyone is only able to see and hear me and the panelists throughout the webinar. Your microphone and camera are not connected, so you don't need to worry about any background noises. As we're going through, if you've got any questions for the panel, please use the Q&A function to submit them. We have Sophie and Grace from the Specialist Nurse team here at Prostate Cancer UK on hand to respond to some of these questions in the chat. We will also have dedicated time for a question and answer discussion at the end, where we'll aim to get through some of the more detailed questions. I'd like to ask that you don't include any personal health information in your question, otherwise we won't be able to answer it. We can't give any health advice on individual cases. Please note that only the questions that we answer will become visible in the Zoom chat. We're sorry if we don't get to your questions this evening. If you're left with any urgent questions, remember that the Specialist Nurse service is available Monday to Friday, 9 AM to 5 PM. If there are any unanswered questions, we will aim to collate them and answer them in a summary email in the coming days. Please note that everything in this webinar is for general information purposes to help you understand and navigate your situation better. It does not constitute medical advice. This webinar will not cover the assisted dying bill that was discussed in Parliament last week, but we will be covering issues that some of you might find challenging. If you find it difficult to listen at any point, you can of course step away. We will circulate a recording of the webinar afterwards, so you can catch up in your own time if you prefer. That's all the housekeeping done, so I'm delighted to be joined by our wonderful panel encompassing clinical expertise and lived experience. I'll let them introduce themselves very briefly. Holly, if you'd like to start.
Good evening, I'm Holly. I'm one of the specialist nurses at Prostate Cancer UK.
Wonderful. And Sarah?
Good evening, I'm Sarah Malik and I'm the clinical lead at Compassion in Dying, which is a charity that supports people to plan for the end of life.
Thank you. And Elizabeth?
Hello, I'm Elizabeth. I am a widow and I'm going to share with you how, even though I really was at odds with my late husband over this, and I struggled with it, planning ahead really did make all the difference to my husband's end-of-life experience.
Thank you very much. I'll hand over to Holly in a moment to get us started properly. But first, we're going to do a quick poll as we'd like to know more about our audience today. So the poll should flash up. Please, can you select any of the answers that apply to you? And don't worry, the answers are anonymous. So the question is, we'd love to know more about our audience today. And the question responses are, I have been diagnosed with prostate cancer. Someone I know has been diagnosed with prostate cancer. I've lost someone I love to prostate cancer, and I'm a clinician or healthcare professional. I'm going to give everyone a minute just to answer, and then we can carry on with the webinar. Okay, I think that's everyone done. So the majority of you have been diagnosed with prostate cancer, and we have some people who have someone they know that has been diagnosed with prostate cancer. So thank you very much for answering that. During this webinar, you will hear about what may happen if your current treatment stops working and what the next steps might look like. You'll also hear about what end-of-life care could mean for you, and you'll find out how advanced care planning can help ensure your wishes are respected, providing peace of mind for both you and your loved ones. I'm now going to pass over to our clinical nurse specialist, Holly, who will give an introduction to what happens when treatment for advanced prostate cancer stops working. Over to you, Holly.
Thank you, Sophie, and good evening, everybody. So I'm Holly, I'm a specialist nurse. I've been working at Prostate Cancer UK for just over 2 years now. Prior to this, I've mostly worked in a variety of palliative and end-of-life care settings, including hospices, hospitals, and in people's own homes. First, I'm going to start off by talking generally about what we mean when we use the phrases palliative and end-of-life care. Palliative care is about offering the right support at the right time. The World Health Organization defined palliative care as improving the quality of life of patients and that of their families who are facing challenges associated with life-threatening illness, whether physical, psychological, social, or spiritual. It also focuses on improving the quality of life of caregivers. Although it can include end-of-life care, palliative care is typically much broader and can last for longer. Having palliative care doesn't necessarily mean that you're likely to die soon, as some people might receive it for several years. Marie Curie described end-of-life care as offering treatment and support for people who are near the end of life, usually within their final year. The aim is to help someone to be as comfortable as possible in the time that they have left, as well as making sure that practical things such as wills or wishes are sorted out. Both palliative and end-of-life care are there to support those diagnosed with cancer, as well as other conditions, including dementia, neurological conditions that affect the nerves and brain, heart disease, and respiratory or breathing conditions. Now I'm going to talk about what we mean by the term advanced prostate. Advanced prostate cancer is cancer that has spread from a person's prostate to other parts of their body. At this time, treatment may be offered to bring their cancer under control, but it can no longer be cured. You might hear prostate cancer that has spread described as metastatic cancer, secondary cancer, or just secondaries, metastases, or even METs. It is still prostate cancer wherever it is in the body. The most common places for prostate cancer to spread is to the bones and lymph nodes. Lymph nodes are part of the lymphatic system, which form part of the immune system and are found throughout the body, including in the pelvic area close to the prostate. Metastases in the bone can cause pain and discomfort, but there are palliative treatments available that can help with this and other symptoms that advanced prostate cancer may cause. In some rare cases, it may grow in or near to the spine and press on the spinal cord. This is known as metastatic spinal cord compression, sometimes abbreviated to MSCC. It is important that anyone who has prostate cancer in their bones or is at known risk of this to be well informed by their medical team of the signs and symptoms, as it is important that they receive treatment as quickly as possible. When should someone with advanced prostate cancer start thinking about end-of-life care? We know that as individuals, the way we live our lives and therefore how we approach sensitive or difficult conversations is different for all of us. Some people will choose to explore their thoughts, wishes, and feelings around their end-of-life care and dying long before, or maybe as soon as they are diagnosed with a terminal illness. This includes a diagnosis such as advanced prostate cancer, when a person may receive treatment aimed at prolonging their life, but which is unable to cure them of it. Although the idea may feel overwhelming, this can be a good time for people to start thinking about their wishes whilst they feel well and strong enough to do so, and talk about and make important decisions. For others, this can be very difficult, so they may choose not to do this until later in their journey, perhaps, for example, when they're further down the line, or have maybe been told that their treatment is no longer working, or they choose not to for quality of life purposes, such as due to severe treatment side effects. Planning ahead can help you receive the care that you want and also help to make things easier for your partner and or loved ones when you are approaching the end of life. Some things, such as telling people you love them or making a memory box with someone to remember you by, could help your family and friends in their bereavement after you die. But again, this is all a personal choice. So how might someone plan for end-of-life care? There is no set way of planning ahead, but there are some useful steps that you might wish to consider taking, which can include starting the conversation. So this might be with your partner, family, carers, and or your healthcare team. Exploring your options, wishes, and preferences, such as where you might or might not wish to be cared for. Legally appointing someone called a lasting power of attorney. Letting people know your wishes by talking about them or writing them down. As well as thinking about your future care, there may also be emotional and practical issues you might want to consider, including any questions or worries you have about your illness and or dying that you would like to discuss, how or where you would like your funeral to be, making memory boxes, books or videos for your family and friends, and addressing legal and financial matters. Some people might have strong feelings about these topics and others might need more time to think about them or to discuss them with their partner and or family, all of which is okay. So where can a person receive end-of-life care? So end-of-life care can be delivered in a variety of settings, and a palliative care team should try to organise for you to be cared for according to your wishes whenever possible. You may not need to move away from home, as end-of-life care can be provided there. Sometimes this is available both during the day or night. To find out whether you can receive nursing or hospice care at home, you could check this with your GP or local hospice. You can receive end-of-life care in a care home where trained staff are available to look after you day and night. And many hospitals have specialist palliative care teams who work alongside and support the hospital doctors, nurses, and other health and social care professionals. And of course, in a hospice. So hospice care is provided by a team of doctors, nurses, social workers, counsellors, and trained volunteers. And they are set up like a home from home where you can bring in personal items that bring you comfort, and your closest relatives are often able to stay with you overnight, as well as maybe even your pets too. If you choose to receive care at home or in a care home or hospice, you should be assessed for NHS continuing healthcare. This is a package of care for adults arranged and funded by the NHS and is available to people who have certain types of health and care needs. It is free of charge to the person receiving the care and is sometimes called fully funded NHS. What to expect when someone is in the last few days of life. Exactly what the final days for someone with advanced prostate cancer will look like will be slightly different for everyone, and the diagnosed person may not be aware of these changes when they happen. But there are common signs and symptoms which may help a loved one know what to expect. People will usually start sleeping more and seem drowsy a lot of the time, spending majority, if not all, of their time in bed. This may have already started happening gradually over the last few weeks or months, and they may not always respond when you talk to them or try to wake them. They may also seem disorientated, as if they are dreaming. Often they can still hear you, as this is usually one of the last remaining senses, so it's a good idea to keep talking to them and offering words of comfort as you normally would. There will also come a time when a person will lose interest in eating and drinking. It's important not to force them to do so. Instead, if they are awake, you can offer them small pieces of ice to suck or small sips of fluid. If they're not able to swallow, you can moisten their lips and mouth regularly with water or with other flavours that the person enjoys, as well as using mouthcare products and saliva replacements, which can be supplied by your healthcare team. You may also notice changes in a person's breathing. It might become noisy or irregular. They might breathe with their mouth open and use their chest to help them take a breath. This can be eased by repositioning them, as well as offering words of comfort and holding their hand for reassurance. Other very natural symptoms we might see in a person who is in their final days can include a loss of bladder and bowel function, their hands and feet and arms and legs becoming colder, as well as restlessness or agitation. It's important to remember that there will be support available to loved ones and carers to help recognise and navigate these symptoms and to help keep the dying person as comfortable as possible. How much does end-of-life care cost? So end-of-life care in a hospital or a hospice is free. Healthcare, such as from your GP, hospice or community nurse, is also free for people who are ordinarily UK residents. Some other services may cost money, including care homes and personal care services at home. This often depends on where a person lives and their financial circumstances. If someone is looking after you, such as a partner or relative, it could be helpful for them to get a carer's assessment to see whether they qualify for financial support during this time. Remember that you're entitled to high quality end-of-life care wherever it is that you receive. And finally, I'm just going to talk about what it's like to be the loved one or carer of someone who is approaching the end of their life. So caring for someone with a terminal illness, such as advanced prostate cancer, can be physically and emotionally demanding. Carers often tend to focus their energy and attention on the person they are caring for, which can mean they put their own health and well-being last. It is important for them to think about their own needs and capabilities to help stop them burning out or becoming unwell themselves. You may find as a carer that your relationship changes with the person that you're caring for. Some people say it changes their identity. They no longer feel like that person's partner, family member, or friend. But I would remind you now of my earlier comment that we are all different and the way we approach these sensitive situations will vary. So there is no right or wrong. Both the dying person and their relative or carer may need alone time during this journey. Sometimes involving children and young people, where and if appropriate in the person's care, may also help them to understand what is happening. Caring for someone at the end of their life can be a rewarding experience and a time of great closeness. You may experience a much deeper relationship with the person, and you may find it reassuring to have been able to play a role in making their final moments as comfortable as possible. It may also help with the bereavement process after the person has died, for which support is available, and you can usually access this through your GP or local hospitals. I'm going to close now with a quote from Dame Cicely Saunders, who was the founder of the modern hospice movement. She said, "You matter because you are you, and you matter to the end of your life." Thank you for listening.
Thank you very much, Holly. End of life is a very difficult time for both people with advanced conditions and their families. So thank you very much for sharing your information with us. I'd like to remind everyone that if you have any questions, please do pop them in the chat and we'll go through them at the end. So now I would like to introduce Sarah Malik. Sarah is the Deputy Director of Services and Clinical Lead at Compassion in Dying. She is going to give us an introduction to person-led advanced care planning, including how people can robustly document their wishes to help ensure they have an end of life that is right for them. Over to you, Sarah.
Thanks so much. Thank you. And thank you, Holly. It was so informative. So my name's Sarah. I'm a nurse by background, but I've spent the last 7 years leading Compassion in Dying's nurse-led helpline. So I'm going to spend the next sort of 20 minutes or so just talking about the ways you can prepare for the end of life, specifically by documenting your wishes. So today, it really is an overview. I won't be able to go into quite the detail that some of you may wish, but any of you have outstanding questions, either pop them in the chat or you can follow up with me directly afterwards. That's also fine, or email me at some point. Firstly, though, I would quite like to just give you an outline of who we are at Compassion in Dying. So we're a national charity and we support people with preparing for the end of life by talking about and then documenting in advance their treatment and care wishes. So we really believe that everyone should be given the opportunity and support they need to make decisions about their treatment and to plan ahead in a way that helps people to ensure that their wishes are known about and followed if one day they later lose the ability to communicate their wishes for themselves. So in terms of how we do this, we have a free nurse-led helpline, which I run. We have free resources for people. We're the leading provider of advanced decisions, and the NHS website in England and Wales actually signpost people to our service. And whilst we used to focus entirely on supporting people to plan ahead for the end of life, more and more actually we're providing support for people who are having difficulty now with either having their own wishes respected, or for people who are advocating or supporting a loved one at the end of life and when their wishes aren't being respected. So moving on, one of the key things we've learned through the research we've done and ultimately from what people tell us through our nurse-led helpline is that there's this really worrying disconnect between what people want at the end of their life and what they're doing to prepare for it. Lots of people across the UK actually have very strong views about what happens at the end of their life. And actually, very few people seem to want a doctor who they don't really know to be making final treatment decisions for them. But despite this, and this is the disconnect, very few people are formally planning and documenting their wishes. Now, I often wonder why this is. I've got a lot of ideas, and I think this is crucial to actually closing that gap and making a difference. So a lot of people worryingly just don't know what their options are. People don't know what they can do to document their wishes. And some people actually think that having a next of kin is enough. And I'm going to be talking about next of kin a bit more later, but actually there's no legal authority when it comes to next of kin. You can't automatically make a decision for a loved one unless you've got a more formal decision-making authority in place, and more people need to know that. A lot of people also wrongly believe that there are financial barriers between them and planning. So to have anything legally binding in place would require a solicitor, and that's also just not the case in most parts of the UK. So I'm going to use this time today, hopefully, to give you an informative overview of the different ways you can document your wishes and the different ways you can plan, to show you what a difference it can make and how you can actually take control, because so many of the people we speak to value independence, value control, and want to retain that and make sure that that's the case even if they lose that decision-making capacity. But I think it's important to stop here and first just talk about decision making and how decisions are made at the end of life. So simply put, having capacity means that a person is able to make or communicate a decision for themselves. So if someone is very unwell and a decision needs to be made about what treatment they have at the end of life, people with capacity will make that decision for themselves, even if that decision refuses life-prolonging treatment and that decision brings about their death. That's absolutely their right and their decision to make. But if you're unwell and you lack the ability to make these sorts of decisions, then a doctor would do this in your best interest, unless you have some formal documentation in place that covers those decisions. So now I'm going to start and give you this overview of the different ways that you can document your wishes and communicate what it is that you do and do not want. So the forms I'm going to talk about just briefly are the advanced statement form, the advanced decision form, and lasting power of attorney for health and welfare. So I'm going to start with the advanced decision. An advanced decision form, also known as an advanced directive and also known as a living will, it's very frustrating. There are 3 terms for one form, but this is a form that lets you refuse any medical treatment that you don't want to be given in the future in case you later become very unwell and you're unable to make that decision for yourself. Whilst you need to complete this form whilst you're able to make decisions, it's only used if you later lack the ability to make or communicate such a decision for yourself. You don't actually have to be ill or old to complete an advanced decision form, but you must be an adult and have capacity to make the decision at the time you complete the form. So to recap, you can use this form to refuse any medical treatment, including life-sustaining treatment, if you don't want it to be given in the future. It's only used if you're unable to make or communicate that decision for yourself. These are legally binding documents in England, Wales, and Northern Ireland. And you can complete these in Scotland, and they would usually be followed as they would in England and Wales and Northern Ireland, but they aren't legally binding there. And at Compassion in Dying, we provide these forms and crucial support to complete them for free. So once the form's been completed and then signed in the presence of a witness who also signs and dates the form, it's then ready to share. And I would like to say here that witness could just be a friend or a neighbour. It doesn't have to be anyone official like a doctor or a solicitor. We then suggest to people who complete this form that they share photocopies of it as widely as they can to help ensure that if it's ever needed or known, it's known about and can be followed. We don't have good record sharing systems in our healthcare services, I'm afraid. Between primary and secondary care, it's very difficult to communicate your wishes. I'm sure you'll all come across this unfortunately. And that means that when you complete this form, the onus is on you as the individual to make sure that it's known about by the right people. So you can share photocopies, which are acceptable, just as acceptable as the original, with your local hospital, your GP practice, your specialist nurse, your friends, your family, your local ambulance service can have a record too. And I'd like to just share a quote from somebody who we've supported, just to kind of indicate what a difference this can make. My husband had an advanced decision form in place which refused all life-prolonging treatment if his condition worsened. The GP had a copy and ensured my husband was set up and kept comfortable at home rather than admitted for treatment he didn't want. So that's all I'm going to say about advanced decisions for now. If you've got more questions about these forms, please do get in touch with me or the rest of the team at Compassion in Dying. But now I'm going to move on to lasting power of attorney. So lasting power of attorney is a way of giving someone you trust the legal power to make decisions for you. There's two types. There's one for finance and property affairs, and there's one for health and welfare decisions. In most parts of the UK, there's the option of having the finance version, but it depends on where you are in the UK as to whether there's the option of having the health and welfare version. So at Compassion in Dying, we don't support people with finance. It's not our area of expertise whatsoever, I'm afraid. But we do support people with queries about the health and welfare version of this form. And we support health and welfare attorneys who aren't being listened to. More and more, we're finding that sometimes sadly the case, but that's now a service that we provide. And why is this important? Well, as I've said earlier, your next of kin don't have an automatic or legal right to make decisions for you unless you've got power of attorney in place. So these people that you give authority to, it could be one person, it could be more than one person, would have the authority then to step in and make decisions for you about all aspects of your health and welfare, depending on how you completed the form. So for example, it could be about where you live and where you cared for. It could cover your daily routine and your diet. It could cover medical care and treatment options, and that could include whether you have a life-sustaining treatment or not. And it can include things like who spends time with you. So these forms are provided by the Office of the Public Guardian. That's a government body, and they're the ones who process and register the forms. People can complete them by hand or online, but it can take now, since COVID, up to 20 weeks for these to be processed and returned. And that waiting time hasn't seemed to have reduced much, I'm afraid. So sadly, what I'm hearing from people is they might have been told, oh, we're not yet there yet, like you don't need to do this yet. But actually, this is not something you can do last minute. This is something that needs to be done well in advance, and then you can leave it and it waits to be ready as and when needed if you ever do lose capacity. It gives people a legally binding authority, and it only comes into effect if you lose the capacity to make your own decisions. There's currently no power of attorney option in Northern Ireland or the Isle of Man, just to be clear. So you need to kind of think, about where you are in the country as to what options you have when it comes to planning, I'm afraid. And again, thinking about how this can influence or impact someone's experience. This person who was in touch with us said that having power of attorney in place meant I could step in and make the decisions Mum would have wanted. I know it gave her peace of mind knowing that I could do this when her condition progressed, and it gave me peace of mind too, knowing I could see her wishes through. And this is something that we hear a lot. It's one thing to think about how it can influence your own treatment and care decisions and outcome, but the other thing to consider with this sort of advanced care planning is the way it can improve the experience of those advocating for you and those involved in your care. So the last form I'm going to talk about is the advanced statement. And this is a form we provide at Compassion in Dying. And it's a way of documenting what's important to you and what makes you you, essentially. People might include things like the following: your values, your religious beliefs, the important people in your life. Lots of people actually that we come across document who they don't want involved or visiting them, to be perfectly honest. Some people add things like their food preferences or their allergies. These things really worry people, and they really worry that someone might not know. these important details of caring for them in hospital or in a care home. You can also include things like where you want to be cared for at the end of life, that there is an option or a choice, and other important information about your health. They'd only be used to guide decisions if you lack the mental capacity to make or communicate these decisions for yourself. And they're not legally binding documents, but that doesn't mean that they don't have value. They can really help to guide decision making when the decision makers don't know you very well, or they can help your power of attorney to sort of prove that they're making decisions in your best interest and to guide them. So they are actually really useful documents and can really reinforce the other advanced care planning forms that you may choose to complete. And you can see on the screen what they look like, the setup of the form. And again, these are provided either in the post to you, or you can complete them online, depending on what you prefer. So one thing that can be really confusing for the people we support is the array of advanced care planning and forms that's out there. So what I've been speaking out about just now is the options you have to document and take control of your own wishes, the ways you can say what it is you do and do not want for yourself. But what's confusing is that there's also forms that your doctor or your specialist nurse might complete for you as well. And so I just wanted to touch on this briefly. There are lots of different versions of forms that your healthcare professional might complete, depending on where you are in the country. You might have heard of respect forms, do not attempt resuscitation, or DNR forms. There's quite an array. And it's not necessarily a case of having either or. Sometimes people have documents they complete with their doctor and documents they've done for themselves. And that's okay. It's all right to have an advanced decision and a respect form. The crucial thing is that they don't conflict with each other, and the people who are looking after you and involved in your care are aware that you may have both in place. And I've just got this extra slide here just to kind of further reiterate how they're different and how they're similar, because they may overlap, but it doesn't mean they're the same thing. So on the left of this slide, you'll see that you've got an image of what a lot of the country will use, which is a DNR, or do not attempt resuscitation form. These are clinician-led documents. That means that a doctor or a specialist nurse would complete it. And it's an emergency recommendation about what should or shouldn't happen if you become very unwell. It's a communication tool. It's one doctor or nurse saying to others what they shouldn't do. An advanced decision can include a refusal of CPR, but it's completed by you. It can refuse any treatment, including any life-sustaining treatment, and in many parts of the UK, they are legally binding refusals of treatment. Whereas a DNR form or a respect form, they're recommended approaches or guidance, they're not legally binding. Whatever you choose to have in place, it's really important that it doesn't stop at the point you make or complete the forms. These documents and this information needs sharing widely in order for it to be known about when it's needed. Depending on what you have, you can share this information with your relatives, your close friends, your GP practice, your specialist nurses, your local hospital even, and your local ambulance service. And actually, the local ambulance service could hold a record of the fact that you have a DNA CPR in place, and it helps them to know if they are called to your home, what it is you do and do not want if you were to deteriorate and become really unwell. Completing these forms is just the beginning, making sure everyone knows what's in place, or everyone who is relevant to your health and care decisions is aware of exactly what you have in place. So I urge you to really think about what matters to you. I deliver this sort of talk to lots of people, not just people who have a diagnosis. Any adult who feels strongly about what it is they do and do not want could do really with considering this sort of planning. And when you know and have had a conversation with those close to you or your healthcare team or both, you can think about how to follow up from that conversation to robustly record your wishes to help make sure that what it is you do and do not want is known about when it's needed. And so I do urge you, any of you, if you'd like to follow up and contact us for more information, if that would be helpful. And that does bring me to an end of my session. Thank you.
Thank you very much, Sarah. I think many people don't actually know kind of what options are available to them in terms of legal documentation. So thank you for kind of outlining what is available and how to complete them. We always hear back feedback that men really value the understanding that people with lived experiences and their partners and situations have. So I'm delighted to introduce our guest, Elizabeth, who has kindly agreed to share her story with us. Elizabeth and her husband reached out to Compassion in Dying to help with their advanced care planning. Sarah supported Elizabeth and her husband to document his wish not to have life-prolonging treatment and to remain at home when his advanced condition worsened. So Elizabeth, thank you for joining us and for sharing your story. Oh, I think you're on mute, just to warn you. It's very common with these Zoom meetings. I think, yeah, there you go.
I do apologise. When I was at work, we didn't have Zoom.
It is only a recent phenomenon, so perfectly understandable. So welcome and thank you for joining us. I'd like to start with asking you kind of what prompted you to begin the process of planning ahead with your husband?
Well, my husband, Alan, was in and out of hospital such a lot, but this journey started by chance a couple of years before he died with a very well-meaning doctor. Alan was unconscious in hospital and I had power of attorney, so the doctor broached the subject of a DNR. I know that's really called a DNA CPR. He broached that with me and the doctor tried so hard to talk to me and I just would not engage with anything he said. The doctor told me what he would want for his own father, and he said how distressed he felt when his patients died on the trolley after CPR, but I just could not get away fast enough from him. I had known Alan all my adult life, and I thought I knew what was best for him. And thankfully, Alan recovered. And when he got home, I told him what the doctor had said, and I thought he'd be so pleased that I hadn't agreed with anything. I remember saying to Alan, it doesn't matter how bad it gets, I'm going to take care of you. And, you know, I felt so betrayed when Alan just turned around and said, but that's not what I want. I don't want to be a cabbage. I would have chosen the DNR. It was a conversation we had never had, and it was such a shock. I was absolutely heartbroken. I was devastated. But Alan wanted to find out more about all this, and the hospital doctor had told me to Google advanced decisions or living wills, and so that's what we did. And there were hundreds of solicitors listed online. And I do remember Alan saying, what do they know about my health? And, you know, we were so fortunate that we found Compassion in Dying instead. They were there online as well, and it was free. So we phoned their helpline, and it was Sarah that I spoke to, but I was still crying, and I really didn't help at all. But for their information and support, Alan would never have been able to organise his thoughts and to begin writing down his own advanced decision. Thank you, Sophie.
Thank you. Sounds like it was a hard time.
It was, but it was worth it.
Yeah. What can I ask, what did the process of planning teach you?
Teach me? Well, 4 things. First, on the subject of CPR, that the hospital doctor did have a point, because I had no idea that it wasn't just straightforward. I thought that if CPR worked for somebody, they just got up and got on with life. I had no idea how bad it could have been for Alan. And then I learnt that this conversation is so much bigger than just DNR. I'm sorry, I know that's DNA CPR, because we didn't know about the other medical interventions and the protocols at the end of life, things that a patient does have a voice and a choice about, providing they can make themselves heard. And, you know, I do have to give credit to our GP, because when Alan eventually took his signed advance decision to her to be put on his file at the GP's, really helped me, and I know it helped him, to know that none of it was final, that Alan could review and change his advanced decision if he wanted to. But he didn't, because he knew what he wanted. But the last thing's important too. That's the GP, told my husband, we all have to die one day, even her. But that those who talked about it to people who could support them, faced it and planned it, would have the least frightening and the best experience. And I think she was spot on there, because Alan was completely calm and accepting in his last weeks and days. And that's left me with the best memories, and it's helped both of us so much. Thank you, Sophie.
Thanks. Can you tell us how you feel the process influenced what happened in his final few days? I know you said that it helped, but can you give us a bit more detail?
Well, if I may, the word influenced isn't strong enough. I have to say, having an advanced decision saved his death, because ultimately having an advanced decision was going to be the only thing which empowered me to stop an unfamiliar doctor sending him to hospital just before he died. All I had to say was, Alan's got an advanced decision, and suddenly the argument was over. Alan's written wishes were respected, and he got exactly what he wanted, to stay at home. You know, if nothing else, the advanced decision saved me from that battle and from a lifetime of regretting afterwards that I might have agreed to the wrong thing. I know Sarah said it's a legally binding document, and I'm just so grateful he had it. He stayed in control even when he couldn't be heard. And I do want to stress that what I'm telling you here is only about what Alan wanted for himself. It might not be another person's choice. But it was so important to Alan not to go into hospital. And I would add that since he died, unlike so many of my bereaved friends talking about their loved one's death, I have never had to say, I don't know if I did the right thing. I have complete peace of mind and certainty that I did, and that Alan got what he wanted at the end of his life. Thank you, Sophie.
Thank you. It's obviously still a very difficult topic to talk about, but I think the key message there was that he was in control and he had the choice, which is so important to have that decision and choice at the end of your life.
It was absolutely critical. He couldn't speak audibly, but it was written down, so he did speak. I'm so grateful.
And if you're happy still to answer questions.
Of course I am. Yeah.
Do you think there's a right time to start this sort of advanced care planning?
Oh, I do, because, you know, for us, this was a conversation we were never going to have. I'm just so thankful that that poor doctor prompted us when he did. And I'm sorry now. I'm sorry that I was such an obstacle, and I really didn't help the discussion, because I would just cry and stall it and make it difficult for Alan to speak. So it really might need to be a series of conversations. But no, Sophie, it's never too soon to think about what you want, and to know that by recording it properly, you will protect yourself, and you really could save your loved ones from such a lot of worry, and possibly, like my experience, from a bit of a battle. And certainly from feeling so guilty afterwards that they might not have got it right. And it is also very comforting to think that you can review and alter your advanced decision, even when it's signed and logged with your GP. It doesn't have to feel final. And I think, I can't remember who said this, I think both Sarah and Holly have said it's vital to remember that it's about you and what you want, not to copy others or be influenced. It was so important to my Alan to die at home if he could. He said when his time was up, he just wanted to go quietly without pain, and definitely without tubes and noises and bright lights. But I have friends who'd choose very differently. It's about what's right for you. And I'd also say that we really didn't know, apart from a DNA CPR, what else there was to plan, and until we talked it through with a specialist nurse at Compassion in Dying on the phone. And that's such a vital part of the planning. Don't rush it. Find out what it is you've got to make decisions about. We were so ignorant, and it could all have been so different and so wrong for Alan if he hadn't sorted it out properly. I'd say it's never too soon to start the conversation, Sophie. Thank you. Sorry.
No, it's all right. I think, I mean, end of life, it's a difficult topic, and you know, it's okay to cry. I think everyone will get upset at some point, and I think I can speak for Sarah at Compassion in Dying that I know that probably our specialist nurses at Prostate Cancer UK and Compassion in Dying as well, they're used to people being very distressed, and they can provide support at any time, even if you're in tears and can't handle that. That is what our specialist nurses and Compassion in Dying are here for. So thank you for sharing that. Kind of last final thoughts. Do you have any tips or any other kind of thoughts that you'd like to share with the audience?
I just think it's so important. I just, I'm really sorry that I do cry when I think about, losing my husband.
It's
but
perfectly natural.
I can really say I don't have to feel guilty. I know we got it right. I know he got what he wanted, and we've all got to die. And his experience was just the best that he could have because he got what he wanted. So I would urge people, you may not be able to talk about it. I think I was a real problem to my poor husband, but my husband could talk to Compassion in Dying, to Sarah.
And it's not just a one-time conversation. If it becomes too much in one sitting, you can always go back. You can always recall the helplines and carry on from where you started. It's it's an iterative process, I imagine.
That's absolutely correct. Thank you. That if I was less emotional at the moment, I would have thought of that. You're dead right, because we did have to ring back, talk a bit, think a bit, talk a bit, think a bit, phone Sarah, phone Compassion in Dying.
And that's why the sooner that you start thinking about these things, the longer you have to process and to go through the forms and work out what it is that exactly that you may want at the end of your life. So
can I just say one thing? I do think
absolutely.
I know that the doctor was trying to talk to me at the beginning, but actually I found it a bit difficult. I felt that was a very quick conversation, and I just didn't have a relationship with the doctor that was trying to talk to me. And I did feel that speaking to Compassion in Dying allowed me the time, allowed my husband the time, allowed both of us the time we needed. So don't be rushed. That's also equally important.
Yes, absolutely. It's a very important part of your life. So take your time and make sure that what you decide is right for you.
Thank you.
Thank you very much, Elizabeth, and thank you for sharing your story. So it's been a very informative and emotional last 50 minutes. So thank you very much for everyone who's spoken. We're now going to make a start on our question and answer session. I have a couple of questions ready, and we have our panelists here who will be able to answer some of your questions. If you still have a question you wanted to ask, please do so. Just remember to not include any personal health information in your question, otherwise we won't be able to answer it. And we can't give any health advice on individual cases. Also, please note that only the questions that we answer will become visible in the Q&A section of Zoom. And we're sorry if we don't get to your question this evening. If you're left with any urgent questions or concerns, remember that the Specialist Nurse Service, Prostate Cancer UK, is available, and so is Sarah and her team at Compassion in Dying. And I will remind you of the details of that before the webinar ends. Right, so for our first few questions, I have a question for Holly. I'm worried about dying. Are all patients in pain at the end of their life?
Thank you, Sophie. So the short answer would be no. I think it's a really common thing that a lot of men with advanced prostate cancer will worry about, that they'll be in pain at the end of their life. It's certainly more common if they have advanced prostate cancer that's spread to their bones, that's caused weakening in their bones over time, or perhaps it's likely, their prostate cancer is pressing on their nerves. So that can obviously cause pain as well. So if somebody does have pain, it's really important that they speak out and get the support for it. And there's obviously lots of things that can be done to help make somebody more comfortable if they do have pain.
Thank you very much, Holly. I have another one for you. Can I decide to stop treatment as I would like to focus on my comfort instead of having lots of side effects?
Yes, great question. And of course, absolutely, you are, it's your journey, it's your body. It's really important, especially if you're struggling with things like side effects of treatment, that you speak out to those that you trust, your medical team, and be honest and open about how you're feeling, how much you're struggling. And it may well be, as I mentioned in my presentation, there are symptoms that come as a result of having advanced prostate cancer, and sometimes men can be offered treatment that's there to help with those symptoms rather than treating the prostate cancer itself.
Thank you very much. I have a question. I don't want to talk about my end of life care as it scares me. Can my family or partner speak to the medical team without me? And I suppose that can be either to Sarah or to Elizabeth. I don't know which one of you would prefer to cover that.
Yeah, I think if someone has capacity, but they just find the topic too difficult, then they can give those permissions to the right people to have those discussions. Discussions are different from decision making, just to be clear though. So yes, they can have those conversations about the situation, but when it comes to final decisions, that would then divert to the individual.
Okay, thank you. And I have a question about what would affect decision making. So what if I have dementia or another condition that affects decision making? Would I be able to complete these forms, or would that be too late? What would the next steps be?
Yeah, so a diagnosis of dementia doesn't mean that you have lost the ability to make decisions, but it will impact decision-making capacity as the disease progresses. So that's, a diagnosis that does, I guess, really influence getting planning sorted before that time occurs. So as you know that it will be impacted in the future, just because you have the diagnosis doesn't mean you can't plan now, but it could impact the future. So yes, it doesn't mean that you can't plan. It's still okay to do an advanced decision or power of attorney, depending on where you live. And it's a good reason not to delay it.
Thank you. And I think this question would probably be for Holly. How effective is pain relief treatment at the end of life if cancer has spread to the bones?
That's a really good question. I think that would obviously vary from individual situation to situation. It would depend on where the pain was, what type of pain it was, how receptive that person and their cancer was to the pain relief that they were administered. As I mentioned before, there are treatments. So we talk obviously a lot about things like analgesia. So things that come to mind would be things like your morphine. But there are also treatments that can help with symptoms of advanced prostate cancer, including pain. So that could be things like radiotherapy, which is aimed at helping reduce pain and inflammation that's caused. So that may be an effective treatment for somebody who's experiencing pain from their advanced prostate cancer. And as I say, it would be a constant sort of needing to review their pain and their pain relief and seeing how effective it was, and maybe changing and trying other things if and when it was appropriate to do so. So I think a really good question, but obviously it would pain can also be very different for one person to the next, so it would very much depend on their unique situation in terms of how effective it was.
Okay, thank you for that. I have another question. It says the person has asked, can I be an organ donor if I have prostate cancer? I don't know who can answer that one, if that's something that we can answer in this webinar.
I get quite a few questions about organ donation, and I think as the whole process, as the laws changed and it became an opt-out, you opt out. So otherwise you're an organ donor unless you've said you don't want to be formally. Those changes took place a year or so back. But it's actually not always that easy to be an organ donor, and a lot of people wouldn't be because of their health or so on. So it really is just, I think, case by case. And based on your health and your circumstances. It wouldn't necessarily be that you can't just because you have prostate cancer, but it may be that it impacts what you can donate at the end of life, depending on the kind of the illness that you have.
And presumably, if you didn't want to become an organ donor, that would be something that you put in which form, the power of attorney?
Well, you can make a point, and you can tell your attorneys and your relatives even, and you can document in a statement or other ways that you don't want to be an organ donor. But the formal way of communicating that would be to opt out via the organ donor register.
Okay, and that would be found online on the NHS website, presumably?
Thank you. I mean, one of your team might be able to find it. I think if you just sort of search opt out, organ donor opt out, you'd probably find the information.
Okay, thank you. I have another question from the chat. My husband finds it hard to listen to the doctor. Each time we go for an appointment, he interrupts the doctor and says, I heard enough. How can I get the support to help me? Don't know who would like to take that one.
Well, I mean, I think we could both probably have thoughts on that one.
Yeah, definitely.
Yeah, sometimes you kind of have, it can help to speak to the doctor in advance or send questions to them if you think, or get a summary afterwards. I think if it's the patient if it's the patient's appointment and they're interrupting, it's really tricky, isn't it, to navigate that? But it's really up to the doctor to make sure that all the information is covered. And if, as a couple, you're finding it difficult to agree on how much information you want to get out of the appointment, I think that's something to try and talk about beforehand, and perhaps have an agreed list of things that you're going to cover in the meeting before you go in. But Holly, you might have something more constructive to add to that. It's a tricky one.
It's a really tricky one, isn't it? I was going to say exactly the same thing about having a conversation as a couple away from the clinic room around perhaps why her husband is interrupting the doctor. It may be that that's something he would do in any given situation, or perhaps it's a way of not wanting to hear what the doctor is saying. So I would try and have a sensitive conversation when the time feels right between themselves around what maybe is behind that, and then try and think of ways, as Sarah said, around that. So is that writing down the most important questions that you want to get out of that appointment, and like prioritizing those, and then trying just to get that level of information. It could be maybe speaking to if there's a clinical nurse specialist that's involved in the husband's care, maybe having a sort of debrief conversation with them around things afterwards, just to sort of pick up on maybe any points that were missed or they didn't fully understand during the consultation. But yeah, again, that it's a tricky one because it comes down to the dynamic of that relationship as well as the sort of health information side of things. So it's, I guess, a very personal one to work through.
I was just wondering when you were speaking, Holly, about the fact that actually prostate cancer can also, like, it can create so many difficult side effects or symptoms, you know, depending on if it's the illness or the treatment. Maybe it's just uncomfortable to have those conversations.
Exactly.
Because of the impact the treatment and so on can have on your personal life. And it might just be that that conversation with the two of you in that meeting is just a bit undermining or upsetting.
Yeah. I was also thinking it could be the husband trying to protect his wife from hearing what the doctor's saying, or, you know, protecting himself. It's very tricky.
And conversely, Elizabeth, you said that you struggled to kind of talk initially when the doctor was kind of trying to talk to you about those kind of things. Do you have any tips for partners about how to deal with that conversation and how they can kind of help themselves to cope in that situation?
Well, I don't know if it's helpful just from my experience to say I couldn't talk to the doctor, but I could talk to Sarah. So perhaps it's a different health professional that might have a different approach that could help. But I do understand, I really understand what it's like not to want to hear and not to want to face. But I look back retrospectively and think, well, thank God we did.
The difference, I suppose, sometimes is you came to me, whereas that doctor came to you. And sometimes it's just about kind of when you're ready, which is tricky.
I will just say one last thing that we did use. It might be irrelevant, but sometimes when you can't speak to somebody, just writing them a letter, it gives them the time and the space to dwell on what you wanted to communicate. And I did find that occasionally with my own husband just helped if we were at stalemate on something.
And I suppose in a way, when you're writing something down, you've got more time. Because when you're having a conversation, it's often quite quick, and you have to answer. Like in that instance, where writing something down, you've got the time to think about what it is that you really want to talk about and say, I suppose.
And I think I was just going to add, just remembering that there is no right or wrong way of dealing with difficult conversations or difficult situations, because we're all individuals, and so the way that we manage these is very unique to us.
Absolutely.
I'm trying to see if we have any more questions, but I think that is it for now. I'm going to, I think if we have no more questions coming in, I will end this webinar. But first of all, I'll bring up a second poll. Thank you so much, Elizabeth, Sarah, and Holly.
Thank you. My pleasure.
Oh, hang on. No, I have a final question come through. Sorry. Who makes the arrangement to find a bed for the patient at end of life? I guess that's one for you, Holly, I think.
Well, that would depend on quite a few different factors. So one of them would be where somebody wants to be at the end of their life. So is that in a hospice, for example? So therefore, they would need to then assess that person's need and how appropriate they were to be admitted to a hospice and whether a bed was available. They would obviously need to prioritise their need against other people, or whether it was that somebody was perhaps in hospital and being discharged to go home to die, then that would obviously need to be orchestrated by the hospital before they were discharged home.
I think the person has said a bed in a hospice. From what I can see in the question.
Yeah, so hospices will have a meeting every morning before the sort of day kicks off, and they will look at anybody on a waiting list for a bed, and they will obviously go through each individual case and prioritize the need for that bed or those beds that are available, and then go ahead and arrange the admission as appropriate.
And is that the same throughout the whole of the UK, or does it kind of depend on where you live? Do you know?
So, I mean, I would imagine the process is probably very similar up and down the country, but our hospices are all generally charities, so they'll be run slightly differently to each other. And it also will depend on things like bed capacity and things like that. So that's often why there'll be services that go into people's homes as well, because not everybody is able to die in a hospice, but they can get that hospice care in their home as well.
Okay,
And
thank you.
just to add that, like, I think with hospices, the vast majority of their care is delivered in people's homes. They're often quite small, and the beds in the hospice are usually reserved for those with kind of higher clinical need, where they require that kind of 24-hour support and care. Many people choose to have hospice care at home, but it's often reserved when we're talking about in-hospice care for the few that really require it. So it's not sadly only about choice. It's, like Holly said, about capacity, which is often minimal, and an enormous amount, like 80% or so, that's a random figure, is delivered, the end of their care is delivered in the community.
Yeah, I think resource plays a huge part in a lot of the decisions that are made. And as Sarah said, the clinical need for that bed, and whether that care can be delivered safely at home otherwise.
Thank you. I think that is all the questions that we have for everyone. Thank you so much for kind of discussing all these issues. That there was a lot to go through, what with the kind of what to expect and all the documentation as well. So thank you so much. That's a lot of information that we've got through. I am going to end this webinar with one more poll. If we could bring up now. So, closing question, how would you rate this webinar? And I'll give just a little moment for everyone to have a chance to answer that one. Looks like a lot of people are clicking on excellent and good, which is wonderful news. I think that's everyone who wants to answer. So thank you very much for that. I wanted to say a huge thank you to our panel, Holly and Sarah, and especially to Elizabeth for sharing her story and for offering so much wisdom and insight into her husband's situation. I know it was difficult, but it will be greatly appreciated by everyone listening tonight. Please keep an eye out on your email inbox over the next few days. We will be sharing a survey to ask how you found this webinar. Your thoughts are vital in helping us shape our information and support, so please take the time to do this. We hope that you to share a recording of this webinar with everyone as well in a few days' time. Don't forget, there's a wealth of prostate cancer information on our website, and our specialist nurses are available Monday to Friday, 9 to 5 on 0800 074 8383. And if you have any questions about the advanced directives or closing power of attorney, compassion in dying is also around. I don't know what your helpline times are, Sarah.
At the moment, just while we're training new nurses, we're operating reduced hours. So it's 11 till 2, Monday to Thursday. And the number is 0800 999 2434. And also people can email us on info@compassionindying.org.uk.
Thank you very much. I will, of course, share this information in the follow-up emails in the next couple of days, so it will be there for anyone who needs it. Keep your eyes out peeled for more webinars. We will be sending out invites by email once they have been finalised in a few months' time. Thanks again to Elizabeth, Sarah and Holly, and thank you to the audience for joining us. Have a good evening, everyone, and take care.
Thank you, Sophie.
Thank you.
Thank you.
Bye.